Our concept is perfusion, and the exemplar we're going to discuss today is mitral valve prolapse as it relates to impaired perfusion. Heart valves control the flow of blood through the heart. They open and close in response to pressure changes caused by the blood flow. Remember that there are 4 valves of the heart. The semilunar ones are on the top, and you can remember that. It's like the moon is up higher. And they are the aortic and pulmonic valves. The valves that are below them are the ones between the atrium and ventricle, also called the AV valves, and they are the tricuspid and mitral. This diagram shows where we auscultate to best hear the valves close, but also shows where the valves are anatomically. Remember that the mitral valve is at the 5th intercostal space midclavicular line slightly medially and is also called the bicuspid valve. The heart valves consist of leaflets or cusps, which are pushed open to allow blood flow and which then close together to seal and prevent any backflow. Each valve has 3 cusps except for the mitral valve, which only has 2, and that is why it is called the bicuspid. I want you to follow the blood as it goes through the heart in this diagram. But first I need to point out that what happens on the right side of the heart happens at the same time on the left side also. So speaking about the right side first, blood comes up from the inferior vena cava to the superior vena cava, emptying passively during diastole from the right atrium through the AV valve, which is specifically the tricuspid on this side, and into the right ventricle. As pressures build and cardiac fibers are stretched, the right ventricle contracts, forcing blood through the pulmonic valve into the pulmonary circulation. At the same time, the left ventricle is full, forcing blood through the aortic valve into the systemic circulation. We hear this as S1, signifying systole. After the ventricles complete their contractions and pressure is decreased, the semilunar valves, which are the aortic and pulmonic, close, and we hear S2. The AV valves, the mitral and tricuspid, open again, and blood moves passively during diastole from each atrium through the AV valves into the ventricles, signifying diastole. This slide shows that systole begins with closure of the mitral and tricuspid valves, and diastole begins with the closure of the aortic and pulmonic valves. We hear this as lub-dub, lub-dub, and that pause is diastole when the coronary arteries are being perfused. Remember also that when we are calculating the mean arterial pressure, that diastole is 2 times longer than systole. This slide restates where the valves are located in the heart. It also shows the papillary muscles that are located in the ventricles of the heart and attached to the cusps of the AV valves, also known as the mitral and tricuspid valves. They're attached via the chordae tendineae. These muscles contract specifically to prevent inversion or prolapse of these valves during systole. I want you to look at this YouTube because it gives you a great visual of what mitral valve prolapse and regurg looks like. Also, after you watch it, look up and understand the differences between regurgitation, stenosis, and prolapse. So now we're ready to do our cardiac assessment. So we start with vital signs, the heart rate, blood pressure, pulse pressure. We need to notice if the pulse pressure is widened because a pulse pressure greater than 65 indicates an increased cardiovascular risk. Then assess heart sounds, listening for S1 and S2, and then any extra sounds or murmurs. We need to assess our patient's EKG strip or 12 lead if available. So do you know how to assess preload, afterload, and cardiac output? Probably not. So I have an article on the next slide that I want you to read because it explains these important concepts in a very easy format. You can either cut and paste the web address, or I have it available on Blackboard for you. To know what is abnormal, we need to know our normals. So normal heart rate is 60 to 100. Preferred blood pressure is to keep a systolic at or around 120. Research shows an increased risk for stroke even if the blood pressure is greater than 140. We need to know the risk factors for heart disease so we can identify them in our patients and do patient teaching to direct them into healthier behaviors. So think about what you know are listed as risk factors for heart disease. Things like family history, high LDLs, low HDLs, high triglycerides, hypertension, smoking, tobacco use, diabetes, insulin resistance, obesity, metabolic syndrome, lack of activity, high sodium intake, and age in men greater than 45 and in women greater than 55. All of these are common risk factors for heart disease. So, when we identify these risk factors or actual cardiac problems, we need then to do patient teaching to enable them to take control of their health. Number one is diet. Historically, we have taught a low saturated fat diet, low sodium, reduction in starchy foods and dairy products, and an increase in fruits and vegetables. Number two is to increase exercise and reduce body weight to one's ideal body weight. Number three would be to stop smoking because nicotine is a vasoconstrictor. And lastly, to reduce stress because stress increases cortisol, which has a negative effect on our arteries. The cause of mitral valve prolapse is unknown. The pathophysiology is when the left ventricle contracts, one or both flaps of the mitral valve flop or bulge back, which is called prolapse, into the left atrium. This prevents the valve from forming a tight seal. As a result, blood may leak from the ventricle back into the atrium. This backflow of blood is called regurgitation. MVP doesn't always cause backflow, though. In fact, most people who do have this mitral valve problem, they don't have backflow and never have any related symptoms or problems. Their mitral valves can still form a tight enough seal even with the prolapse. As far as symptoms go, they are varied. Many people have no symptoms. A few experience anxiety, fatigue, regardless of activity level or amount of rest or sleep, shortness of breath that is not correlated with any activity level or pulmonary function, palpitations, atrial or ventricular dysrhythmias can occur and can result in lightheadedness, dizziness, or syncope due to a decreased perfusion to the brain. Some people may have chest pain, which is localized to the chest and not correlated with activity, and it can last for days. This problem of mitral valve prolapse is most often seen in individuals that are 50 or older, male, those with Marfan syndrome, and you can read the rest of these. These are just common situations in which mitral valve prolapse can be seen. So the assessment finding that you would expect would be a murmur due to a narrowed or incompetent valve. You need to assess the sound, if it is loud or soft, if it is during systole or diastole. A holosystolic or pansystolic murmur will start at S1 and extend up to S2. Pansystolic murmurs are usually due to mitral valve or tricuspid valve regurgitation, and if regurg does exist, the patient may experience heart failure symptoms. An echocardiogram is the best diagnostic test to look at the heart valves. And if the patient is symptomatic and requires medication, they can be put on either beta blockers to reduce cardiac workload, diuretics to reduce volume, antiplatelets to reduce the risk of clots forming, and or anti-anxiety medications. If surgical management is required, the valve can be repaired or replaced. Valve repair, though, is preferred when possible, as it is less likely to weaken the heart. Repair also lowers the risk of infection and decreases the need for lifelong use of blood thinners. If repair isn't an option, though, the valve can be replaced. Mechanical or biological valves can be used as replacement. The mechanical valves are man-made and can last a lifetime, but require the client to be on blood-thinning medications for the rest of their lives. The biological valves are usually taken from cows or pigs, and clients are not required to take the blood thinners for the rest of their lives. The major drawback to the biological valves is that they do weaken over time and usually last about a decade. There's really no prevention known for mitral valve prolapse, so care revolves around management of symptoms or surgical repair. The only dietary restriction would be to reduce the intake of caffeine, alcohol, or ephedrine-type products and sinus medicines and cold medicines, as these can cause palpitations and irregular heart beats. This slide is here to help show you how to grade a murmur according to its intensity. It's a scale from 1 to 6, 1 being so faint that you can barely hear it, and 6 being so loud that you can hear it with your stethoscope off of the patient's chest.